And now I've brought my partner, Mayra Herrera, with me, and we're going to talk to you about a hormone that controls salt addiction within the brain. Mayra? So, starting with the quote, eating too much sodium, a key component of salt, can contribute to high blood pressure. A major risk for most people as they age because it can lead to heart disease and other conditions. But cutting sodium from the diet is difficult because people often don't know it's there. Now, our daily recommended salt intake is less than 1.5 grams per day, but we as Americans eat over twice that much every day. Intersalt, an international study comparing sodium intake levels to heart disease, looked and found that the Yanomamo and Xingu Indians of Brazil and tribes in Kenya and Papua New Guinea ate only like 1 to 3 grams per day and had the lowest rates of heart disease of anywhere in the world. Now, some of our typical healthy meals contain 2.2 to 5.4 grams of sodium per day, more than our daily allotment, and sometimes more than 3 times more. Now, sodium insufficiency can be caused by mood swings, Addison's disease, gastrointestinal losses, acute sodium loss from sweat, chronic fatigue, and hypertension. Now, sodium excess can lead to renal disease, osteoporosis, and hypertension, which can be caused by atherosclerosis, coronary artery disease, stroke, and vascular dementia. So in the lab, we want to try and be able to induce this so that we can study how it works. And how this usually happens is through endocrine drug treatment with furosemide or furosemide and capricol, or water deprivation, which is the natural route, and with the natural route, we can study addiction, whereas the drug route would only give acute salt intake enhancement. Now, there are 2 types of salt intake: spontaneous, which you do on a daily basis, and induced, which happens after some sort of a challenge, like the drug or the water deprivation. So, there have been studies previously that found that repeated cycles of water deprivation and partial rehydration followed by a sodium appetite test will enhance sodium intake in rats. Now, both forms of sodium enhancement, or sodium intake enhancement, are altered by different sets of genes within the hypothalamus, as you can see here. So, in a previous study, we found that TRPV4, a sodium ion channel within the brain, and interleukin-1A, an inflammatory cytokine, are both enhanced within the hypothalamus of rats that have been subjected to this WDPR protocol. And the theory behind this is that, and there was no blood chemistry for any of the sodium or potassium ions or changes in the osmolality of the blood. Now, the plasma vasopressin levels were also measured and were not found to change. So the theory with this is that sodium ions are coming in, causing more action potentials to be sent down the neurons being stimulated by these TRPV4 channels, and causing some neurotransmitter to be released within the brain. Now, moving on to the daily sodium intake enhancement, that addiction, we've seen that AVP levels were raised almost 17-fold. It was a great amount in the 3-WDPR group. And we also saw that plasma AVP levels were raised while not affecting sodium or potassium concentrations in the blood. So now we're thinking that these enhanced signals are not only sending AVP out within the brain, but out into the bloodstream as well with these increased action potentials. So what we wanted to look at was the vasopressin, that polypeptide neurotransmitter that was located within the brain, with the correlation between it and the salt intake enhancement. AVP has 3 different receptors. 1A moderates food intake and locomotor activity. 1B moderates fluid intake, body temperature, anxiety and depression, and 2 is an autoregulatory receptor. When AVP binds to it, it shuts down the release of AVP, so you don't get too much. So Previous experience with AVP in the brain causes rats to increase their sodium appetite after just a single episode of sodium insufficiency. Now, our objective was to investigate the effects of intracerebroventricular or ICV injection of AVPR1A, AVPR1B, and AVPR2 antagonists on the salt intake enhancement induced by the water deprivation and partial rehydration cycles. Mayra, could you tell them what we did?
Yes. Adult male Scarlatti rats were individually housed with access to chow, water, and 1.8 hypertonic sodium chloride solution. The experimental design consisted of 1 week pre-surgery, 1 week post-surgery, and 3 weeks where sodium, water, and chow intake were recorded closely, with two 7-day intervals of the WDPR SHE protocol. And you can see body weight and body temperature were measured at the beginning and at the end of each week. For the stereotypes of surgery of the lateral ventricle, the hair was trimmed around the surgery location, rats were anesthetized with triboma ethanol, ear bars were placed into the mastoid process of the temporal bone, and the maxilla was inserted into the mouth bar on the animal fixation for animal fixation on stereotype equipment, and the scalp was open. The Bregma suture was located at 3D coordinates, anterior, posterior, vertical, and lateral. A skull opening was drilled at 3.7 millimeters posterior to and 0.4 millimeters lateral to the Bregma. 2 anchor screws were inserted ipsilateral and contralateral to the drilled opening. The guide cannula of 10 millimeters was inserted into the opening at a depth of 1.6 millimeters from the dura mater. Cannula and screws were then coated with dental cement. The dental cement was allowed to fully polymerize and harden, and the animals were removed from the stereotyping equipment. The guide cannula was sealed with a twisting cap to avoid clogging passageway by debris and blood clotting. The animal was monitored while recovering from anesthetic and surgery, and fully awake animals were returned to the cage in the animal facility designated room and administered penicillin IM as post-surgical care and on the following day to minimize infection and pain. So let me tell you about the water deprivation partial rehydration, SHE protocol. It begins with 36 hours of water deprivation, where water and the sodium are removed. At the end of the 36 hours, body temperature is measured and the chow is removed, and only water is given. And they're allowed with water for 2 hours. At the end of these 2 hours, body temperature is measured and water intake is recorded, and this is known as the partial rehydration period. And for another 2 hours, they're allowed sodium and water, and at the end of these 2 hours, the sodium and water intake is recorded, and this is known as sodium appetite test. Now, this would be what you would call the normal WPR protocol, and for this experiment, we injected 2 drugs, AVPR1A and AVPR2 antagonists, and AVPR1B antagonists. These drugs were injected 12 hours into the water deprivation, and again 1 hour into the partial rehydration. The results for spontaneous or daily intake. On the x-axis, we have our days, and the y-axis, we have the daily sodium intake. The red squares represent the AAVPR group, which is the antagonist for vasopressin receptor, and the black squares represent our control group. You can see here that the control group increased after the first and after the second water deprivation, partial rehydrations, when compared to the first week. And you can see a significant difference within the AAVPR group and the control group after the second WDPR. Daily water intake did not differ at all between the 2 groups, and this was expected because the addiction is specific to salt. For daily chow intake, we see that the control group increased after the second WDPR when compared to the first week, and the AAVPR group was significantly lower than the control group after the second WDPR. This is telling us that the animals are seeking the salt in the chow also. For our body weight, both groups increased pre-surgery and control group increased post-surgery, and both groups remained constant throughout the entire experiment. Body temperature, we see that the AAVPR had an increase in body temperature after the first WDPR and right before the second. And this again was expected because ADP acts as an antipyretic, and blocking its receptors will cause the opposite effect. Jake, will you tell us more about results?
I would be happy to. So this stimulated or induced intake is what happens immediately after our treatment. And during our 36 hours of water deprivation, we can see that there was no change in body weight, chow, or body temperature between the two groups, meaning that they're going into this study exactly the same amount of dehydrated. Now, looking at their water intake during the 2 hours of the partial rehydration, you can see that our AAVPR group in the blue was significantly lower in both cycles, and which means that AAVP blockers are blocking the action of vasopressin to cause them to seek more fluids. And body temperature was raised again, as in Mayra's, because the AAVPR blockers are preventing the antipyretic action. Now, during the sodium appetite test, you can see that there was a significant change in sodium levels in the red compared to our control white groups, and there was also an enhancement from the first to the second cycle in the white group, which we would expect since we've done this procedure before with the normal controls, and that's what has been coming out historically. But the water intake was not statistically different in this cycle, meaning again that once they have that sodium, they're going to have the preferential seeking of it, but the AAVPR is blocking that. Going on to the temperature during the sodium appetite test, there was no change here, presumably because the AAVPR may have worn off, or AAVPR blockers have worn off by this time. And so we concluded that the administration of ICV vasopressin receptor type 1A, 1B, and 2 antagonists prevents the enhancement of both daily and stimulated sodium intake induced by the repetition of WDPR protocol. Thank you. Any questions?
Based on Catherine's data, what do you guys expect that could be happening with vasopressin receptors type 2 in the kidneys of the animals that received, in the animals that you guys treated?
Well, if you have an enhancement normally in the receptor type 2 to combat that overflow of vasopressin in the bloodstream, it could possibly be increasing the amount of the type 2 receptors within the kidneys.
So, okay, that's what you saw. So what did you see? And so if we were to take the kidneys from the animals you guys treated, you guys blocked the vasopressin in the brain. So if you were to take that kidney, what do you think you would see with those vasopressin receptors, those animals?
Probably a lot more diuresis in the urine. If the vasopressin receptors are blocked, they're not going to be preventing the voiding of the urine.
We'll just see an increase in the vasopressin because it has an over to it. The receptors are blocked, so we can't bind the receptors.
Yeah. Are there other questions?
Okay, so let me keep that question. So what do you think, Catherine?
I think it should be done right away. Because they're, the ones that were treated with
antagonists did not show an enhancement, whereas with mine, the ones that showed an enhancement did have that upregulation of ABPR2. So then if they're blocking that, then I should have a downregulation of ABPR2. Or I don't know, I just saw it decrease.
Why not change it
Oh,
up?
yeah, or it's on the 2000.
You're blocking the brain, no enhancement. So that is like the good house animals that do not show an enhancement and you didn't change the receptor in the kidneys. So. Thank you.
Do we have other questions?
For injection, how did you choose at what point to inject the rights? Like I know it was one 1 hour into the partial integration and 2 hours prior to. Why those specific ones?
Because that's when ADP that's when previous studies showed where ADP was the highest.
So what was the purpose of cutting open their little brains?
Our drugs won't pass through the blood-brain barrier.
So you had to actually put them in the brain?
Yes, we have to put them
I
directly
think
in
you
the
told us
brain.
that. So you injected, but you never said you injected in the brain.
Yes.
Any more questions?
What's the real life application of this? I mean, we're a drug that's too big to pass through the blood-brain barrier. How is this test going to apply anywhere in a real life scenario if you have a patient who needs this, like vasopressin levels are super high, and how is this going to be like anywhere feasible in real life?
Well, what we were finding out is the exact effect of the vasopressin, not actually trying to find some sort of a clinical application. We would need a different drug if we were going to try and administer it orally or, clinical procedures to have them injected. These sorts of things could help with the obesity epidemic. Lots of our food intake problems have a pairing between the hedonic of salt and fat going together. They usually pair and cause you to desire more and more of them, and that's part of the problem here in the States. So if we could possibly block vasopressin for this with something else, now that we know that vasopressin is the one that's causing the salt intake enhancement, it could be put toward further use there.
Okay, so if we're completely blocking vasopressin, how does that affect the sympathetic and parasympathetic system of fight or flight? Because vasopressin or ADH is going to kick in whenever you're running away from something because it's going to prevent you from having to use the bathroom or stop digesting food or stuff like that. How is that going to affect our response time in situations where it's either you die or you run? Does that make sense?
Yes, I'm not sure that it has any real bearing on the study right now. We're looking for ways that we can possibly change the diet. If someone is obese because of a salt addiction problem, they're probably not going to be in many situations where a faster reaction time is
Do we have any further questions? All right.
Let's